My name is Vera Regitz-Zagrosek. I'm coming from Germany, from Berlin, and I am a cardiologist and at the same time the director of the Institute for Gender in Medicine at Charité University Medicine Berlin. Today I gave an overview on sex and gender differences in cardiovascular disease. I first pointed out that it's very important, if you analyze sex and gender, to do this with an unbiased approach, comparing women and men, to use a solid, unbiased, unemotional methodology, looking at inclusion criteria, case numbers, and statistical methods in your studies. It is also equally important that you focus on large studies in journals that do have a good reputation and undergo a serious peer review procedure, because this field is a bit emotional, and as in other scientific fields, a number of small, strange, and personally biased viewpoints are around. We compare in our studies first sex differences, the biological differences between women and men, and at a next step, gender, what means the socio-cultural difference between women and men coming from education, from the environment, from the society. And this gender determines disease behavior, disease attitudes. If you focus on the large studies, you can easily find that there is a significant difference in women and men in risk factors. For example, diabetes, which is a much larger risk factor in women than in men. So in risk factors in women and men, in the pathophysiology of coronary artery disease, and in outcomes of cardiovascular diseases. The manifestation of most cardiovascular diseases occurs later at lifetime in women than in men, but frequently the disease is more severe in women. There are few cardiovascular diseases that affect almost only women, like the Takotsubo cardiomyopathy. There are others that occur preferentially in men, like ischemic sudden death. I gave an example of genomic differences at myocardial hypertrophy, where we analyzed the genomic profile, the gene expression profile, in patients undergoing aortic valve replacement, and I showed that men have a greater tendency to develop fibrosis and ventricular dilatation than women. We then studied the response of the left ventricle towards estrogen supplementation, and we found a number of genes that respond differently to estrogen in male and female hearts. And one of these genes, as an example, is upregulated by estrogen only in male hearts. And this gene, MYLIP, decreases another gene, the myosin light chain kinase, that is associated with contractility in male hearts only. So estrogen, and we showed this then in mouse hearts, induces a decrease in myocyte contractility only in male, not in female hearts. This may be of clinical relevance in elderly men that quite frequently have relatively high serum estrogen levels. So this is just one example where a careful analysis of a sex-specific effects leads to an important clinical finding.